Good morning, everyone. Today we will talk about procedural errors, mainly perforation. A clinician may face unwanted situation during root canal treatment, which affects the prognosis of endodontic therapy. These procedural accidents are collectively termed as endodontic mishaps. Endodontic mishaps may have dentolegal consequences. Thus, their prevention is best option both for patient as well as the dentist. Moving on to the classification, it is classified broadly as inadequately cleaned and shaped canal system, instrument separation, deviation from the normal root canal anatomy, which includes zipping, stripping, and canal transportation, or inadequately prepared canal, and the perforations and obturation related, such as over and under obturation, vertical root fracture, and instrument aspiration. So moving on to the perforation in detail, it is nothing but a mechanical or pathological communication between the root canal system and the external tooth surface. It can be cervical, midroot, or apical level depending upon the site of perforation. Coronal perforations occurs during the access cavity preparation, whereas the root canal perforation can occur at three levels, that is the cervical, midroot, or the apical root. The cervical root canal perforation occurs when we try to locate canal orifice or flaring the coronal third of the root canal. The first and classic sign will be a sudden appearance of blood from the canal. Moving on to the midroot perforation, it occurs due to over-instrumentation and over-preparation of thin wall of the root. This also has a classic sign of sudden appearance of bleeding into the canal space. And coming to the apical root perforation, it occurs when the instrument goes beyond the confines of the root canal and by the overuse of the chelating agent along with the stripe and the stiffer large-sized instrument to negotiate the ledge, canal blockage or zipping, etc. So moving on to the factors affecting the prognosis of perforation repair, it includes the location. So when the location is at the alveolar crest or coronal tooth, the prognosis is obviously poor due to the epithelial migration and the formation of periodontal pocket. And when it is at the furcation area, the prognosis is very much poor. And when the perforation occurs at the midroot or the apical part of the root, there is a good prognosis. And coming to the size, when there is a smaller perforation, there is less tissue destruction, which leads to a better prognosis. And when the perforation size is large, there is large tissue destruction, which will lead to poor prognosis. And visibility and accessibility of the perforation site also plays a major role in the prognosis of perforation repair. Moving on to the time, it should be repaired as soon as possible because as the time passes, it leads to loss of attachment and sulcular breakdown, which will eventually affect the prognosis of the particular tooth. And moving on to the associated periodontal condition, when the attachment apparatus is intact without the pocket formation, a non-surgical repair is recommended. Whereas when there is a loss of attachment, a surgical treatment is recommended. Of course, the aesthetics will also influence the perforation repair and the material to be used. So, what are the various materials that can be used for perforation repair? It includes indium foil, zinc oxide eugenol, intermediate restorative material, cavit, glass ionomer, amalgam, POP, calcium hydroxide, hydroxyapatite, decalcified freeze-dried bone, calcium phosphate cement, MTA, biodentin, bioaggregate, endosequence. And the MTA, biodentin, bioaggregate, endosequence provide a favorable outcome for perforation repair. So what are the ideal properties that we expect from a perforation repair material? The perforation repair material should be able to adhere to the preparation wall of the cavity and seal the root canal system. It should be non-toxic, radio-opaque, and dimensionally stable. It should also be well tolerated by the periradicular tissues, and it should be non-absorbable and it should not corrode. Moreover, it should not be affected by moisture and it should not stain any periradicular tissues. Coming to the treatment sequence, the defect should be repaired prior to proceeding with the definitive endodontic treatment because it enables the clinician to control bleeding, confine irrigation, as well as to achieve a fluid tight seal. First and foremost, we should achieve hemostasis. So when there is a massive bleeding upon entry, hemostatic agents can be used. If not, you can also proceed with calcium hydroxide. It is passively syringed into the canal and it is allowed to remain in the canal or the defect for 4 to 5 minutes or even longer. When the proper hemostasis is achieved, it is flushed using sodium hypochlorite. 2 or 3 applications of calcium hydroxide is placed and then it is removed, which will eventually control bleeding. If the clinician cannot obtain hemostasis, the calcium hydroxide can be left in the canal space until a further appointment. When you achieve a proper hemostasis, control placement of a restorative material can be proceeded. And the barriers help to produce a dry fill or a backstop for placing the restorative material. Collagen material is contraindicated if you are using a bonding based procedure. And calcium sulfate is a barrier of choice if you are utilizing a wet bonding material. After the placement of the barrier, select a restorative material that is easy to use, non-resorbable, biocompatible, and provides a complete seal. And in a coronal third preparation, a calcium sulfate barrier in conjunction with the adhesion dentistry is generally used. MTA can be a material of choice for coronal third defects. Recently, biodentin is widely used. So what are the precautions that can be taken to prevent perforation? You should be able to evaluate the anatomy of tooth before starting the endodontic therapy. And use of smaller and flexible files for a curved canal can be helpful. And recapitulate then and there with the small files between the sizes. Use anti-curvature filing technique in the curved canals to selectively remove the dentin and minimize the overuse of Gates Glidden too deep or too large, especially in a curved canal. Also, avoid the overuse of chelating agents. Sometimes there occurs perforation during the post-phase preparation. This is called iatrogenic perforation. It mainly occurs when there is a poor clinical judgment and improper orientation of the post-preparation drugs. It is suddenly recognized by the appearance of blood in the canal. It is also recognized radiographically. So what is the treatment protocol for it? You can use the perforation repair material like dental amalgam, calcium hydroxide, GIC, composite resin, and freeze-dried bone or tricalcium phosphate to repair the perforation site. So the prevention can be, you should be able to evaluate the root anatomy and its variation and avoid excessive use of Gates Glidden or piezo reamers to cut the dentin. Thank you.